All right. Looks like we are live and recording, and so we're ready to go. Welcome, everyone. Welcome. This is our last session of the day. I hope you guys have gotten some knowledge today. I know there's some very interesting topics and thought pieces that I have witnessed and I have seen. So I hope you all have enjoyed your day so far with us in the CRA conference. So welcome to the session. We are going to talk about our value and what we're worth and our economic evaluation. And my name is Alexandria. I'm a CRA board member, and presenting today is going to be Tracy Abzug and Todd Olmstead. And so I'm going to go over their bios shortly, but I wanted to get some housekeeping done for everyone before we get started. Once the presentation gets started, I will go into the chat box and I will give you your ENCODE so that you guys can get your CEUs. So I'll give you your ENCODE at the beginning of the session, and then I'll give you your OUTCODE at the end of the session. And while we are all cued in and learning from Tracy and Todd, I encourage everyone, if you have questions, to please put those questions in the Q&A section of the chat box. We have a public chat and then a Q&A and then some other features. So if you do have questions, go ahead and place that in the Q&A, and we'll have about 15 minutes or so at the end to dive into everybody's questions. But without further ado, I would like to get the bios going and tell you guys a little bit about Tracy and Todd. So first we'll start with Tracy Abzug. Tracy started her social work career at Integral Care in 2008 and returned in 2013 as a manager of a crisis residential unit. In between, she worked at the local state hospital as a social worker and as a program manager, implementing the person-centered recovery model throughout the hospital. She also has experience working in emergency departments. She currently oversees the crisis residential continuum at Integral Care. In this role, she supports the mission of healthy living for everyone. As a clinician with 11 years of experience in the mission in behavioral health, 8 of which have been in a supervisory and management capacity, Tracy's professional interests are in psychiatric crisis intervention, the person-centered recovery model, and systematic influence. In addition to her full-time work, Tracy is an independent contractor who conducts behavioral health assessments to Army National Guard soldiers who are preparing for or returning from deployment. Tracy conducted a poster presentation at the National Council on Behavioral Health in 2016 and was interviewed and published by Mental Health News Weekly on innovative leadership. In 2019, Tracy presented at the Crisis Residential Association's annual conference on program optimization. Thank you for joining us, Tracy. Todd Olmstead is an associate professor of public affairs at the LBJ School of Public Affairs at the University of Texas at Austin. Prior to his appointment in 2013, he was an associate professor of public policy at George Mason University School of Public Policy, where he was the recipient of the 2011 Teaching Award. Olmstead is a health economist on several large grants funded by the National Institute of Health in the area of behavioral health. Current research projects include estimating the cost effectiveness of integrating substance abuse treatment services directly into hospital inpatient units, providing mental health services to low-income, pregnant and parenting women living in public housing systems, providing early childhood obesity prevention programs to children attending Head Start centers, providing financial incentives to promote initial and repeat HIV testing among high-risk women, and providing financial incentives to promote job-seeking activities among unemployed persons living with HIV/AIDS. In addition to his work in healthcare, Olmstead has published in areas of intelligent transportation systems, highway safety, and administrative rulemaking. I'd like to welcome Tracy and Todd, and everybody, please join us as we learn a bit more from them, and we'll be open for Q&As after the session. Thank you.
start.
Hi, and welcome to What is Our Worth? An economic evaluation. My name is Tracy Abzug. I'm a licensed clinical social worker, and I work at Integral Care, which is a local mental health authority in Austin, Texas. The past 8 years, I have managed residential programs, and more recently, I'm overseeing 4 of our bed-based programs. I've had the opportunity to present last year in Michigan, and I feel very fortunate to be back this year. I would like my co-presenter, Todd Olmstead, to introduce himself as my co-presenter as well as the author, one of the authors of this study.
Thanks, Tracy. Hello, everybody. My name is Todd. I'm a health economist at the Dell School of Public Affairs at UT Austin, where I spend most of my time doing economic evaluations of different healthcare programs, primarily in the area of behavioral health. So today, Tracy and I are going to present the results of an economic evaluation of one of Integral Care's crisis residential programs called the Inn. She'll tell you a lot more about that shortly. But first, I just want to mention that this work is done jointly with our colleagues Paul Rathouz and Steve Strakowski at UT Austin's Dell Medical School. Okay, back to Tracy.
So we hope you walk away with an understanding of how Integral Care partnered with an independent evaluator to complete an economic evaluation on the Inn, as Todd mentioned, as well as understand how the study positively supports the use of crisis residential programs. Next slide. Quick overview of what we'll be talking about today. I'm going to give you all an overview of the Inn, so you have a concept of what this program entails. Todd will talk about the study description and results of the analysis. So the Inn, we are a 16-bed, community-based crisis residential program. This program serves up to 16 adults. There are no gender restrictions on who can admit, and it is a voluntary program. This facility is unlocked, provides structured programming on a daily basis, including evenings and weekends.
It looks like we might have lost some sound for a second. Everybody bear with us. We will troubleshoot that and see if we can get going quickly. Thank you all for chiming in and letting us know that we don't have sound. We're gonna take a look at that and get back with everyone shortly.
At the Inn include crisis assessments, stabilization, medications, therapy, both individual and group, services, weekday peer support, of course, is our nurses station, and you can see straight ahead down the hallway is the entrance to the inn. And the photo on the right is an example of one of the bedrooms. I know it looks bare, but as you all probably understand, the furniture and the layout and the design is intended to be suicide safe and decrease risk. The staffing that supports the inn includes a program manager who is the licensed clinician on staff. This site has case management 7 days out of the week, roughly spanning from 8 a.m. to 8 p.m. We have a peer support specialist that also helps serve the individuals at the inn, and that's a typical Monday through Friday position. Like I mentioned earlier, we have 24/7 nursing. We have 24/7 mental health techs on site. We have a half-time nurse practitioner who provides, of course, the medication therapy for these individuals. In addition to the core staffing, to ensure that there's after-hours support, we have a 24/7 on-call medical provider, nurse supervisor, and a licensed clinician as well. Next slide.
All right.
I'm going to pass it on to Todd to further discuss the study description.
Sure. Thanks, Tracy. All right. I want to spend a couple minutes just telling everybody how this study was set up before I get into the analyses and the results. So the study period was 3 years, beginning in fiscal year 2017. And during that 3-year study period, there were 1,371 unique integral care clients who stayed at the inn. And of those combined, those 1,371 unique clients, they combined for a total of 1,730 inn episodes during that 3-year period. Now, because you can tell some of these clients had more than one stay at the inn during the study period, we defined for the purposes of our analyses that the index inn episode, the one we're going to focus on, was the first inn episode within the study period for each client. Now, we got rid of 11 of these episodes because they were just too long. So 11 of these episodes had very long lengths of stay exceeding a month, which is not consistent with the goals of a short-term acute crisis residential program. So of the remaining 1,719 in episodes used in the study, the average length of stay for the index episodes was 8.59 days, and the average length of stay for the subsequent in stays or in episodes was 8.73 days. Now, our analyses, we took two different perspectives. The first two analyses I'm going to tell you about were conducted from the perspective of the healthcare system, while the last analysis I'm going to tell you about was conducted from. I want to tell you is that we didn't have a comparison group. So the savings estimates that you're going to hear about in analyses 2 and 3, these we had to rely on this notion of benefit transference. Now, benefit transference, that's just a fancy way of saying that we had to rely on the work conducted by others in order to come up with our estimates. I'll tell you a lot more about that when we get there. All the costs you're going to see were measured in 2019 US dollars, and these are actually resource costs. This is what it costs to provide the care. These aren't prices or charges or reimbursements. All right, so let me tell you about our analyses and our results. So our first analysis simply characterized the cost to the healthcare system over time for patients who stayed at the inn during the study period. So specifically, you can see we've got a bunch of stacked bar charts, and the stacked bar right in the middle, the one that's mostly maroon, this is the average cost of care to the healthcare system while patients had their index episode at the inn. And you see it's a little bit more than $3,000 on average over that 8.5 days during their index stay at the inn. Now, in addition, we looked at the monthly cost to the healthcare system during the 6 months preceding admission to the inn and the 6 months following discharge from the inn. We also disaggregated costs by residential versus inpatient versus outpatient, and also by whether integral care provided the care or somebody else did. So for example, the blue piece of each stacked bar represents the cost of residential care provided by integral care. The maroon piece, which is actually a special case of blue, that's right here during the index in stay, that's just the cost of the stay at the inn to integral care. The green piece of each stacked bar is the cost of inpatient care that was paid for by integral care, but provided by others. The orange piece is the cost of inpatient care provided by others, but not paid for by integral care. The gray piece is the cost of outpatient care provided by others, and the red piece is the cost of outpatient care provided by integral care. Now, if you look at the temporal pattern, we see, not surprisingly, that there's a gradual increase in the monthly cost of the system leading up to admission to the index in stay, which again is right there in the middle. And we see, again, not surprisingly, that there's a decrease in the average monthly cost in the 6 months following discharge from the inn. One interesting observation is that the average monthly cost in the month following discharge is quite a bit higher than the average monthly cost in the month preceding admission. And I'll talk more about that later. Now, one thing we can do is break down this overall average cost profile by a couple of interesting client characteristics. So we'll do that first with residential status. So what we have here we can see that the pattern and the magnitude of the costs to the healthcare system varies over time by residential status. So for example, clients who aren't homeless, that's the upper left stack bar chart, they have symmetric and relatively lower costs over time compared to their homeless counterparts, which is in the bottom left. So notice that the homeless clients, they also have increasing monthly costs prior to admission, but then much higher costs following in the 1 month following discharge compared to the 1 month preceding admission. Very different pattern compared to the not homeless group. And also, you can probably eyeballing it that the cost following discharge tend to be a little bit higher for the homeless group. The marginally homeless group, you can tell visually, they're a hybrid between the homeless and the not homeless group. Now, we can also parse these data by the primary psychiatric diagnosis at admission. So let's take a look at that next. So here we see that the costs over time also vary by primary psychiatric diagnosis at admission to the inn. So for example, bipolar patients in the upper right, they tend to be the least expensive to treat, while depressives down here in the lower left, they are the most expensive. So that was it for our first analysis. We simply wanted to get a handle on what it costs to the healthcare system to provide care over time to patients who stayed at the inn. So let's move on to the second analysis. Now, our second analysis determined that the annual savings to the healthcare system from using the inn instead of a psychiatric inpatient setting range between $1.3 and $2.9 million. Now, you can think of this as a measure of system efficiency. In other words, using the inn as opposed to a psychiatric inpatient setting saves quite a bit of money to the healthcare system. Basically, you can do more or less the same thing for a lot less money. Now, the reason for the large range between the $1.3 and $2.9 million is because we use two very different methods to estimate it. So specifically, the first method, the one that came up with $1.3 million as a savings, that one assumed that the inn is 42.5% less expensive than local hospital alternatives for patients with psychiatric diagnoses. Whereas the second method, the one that came up with $2.9 million, that one used HCUP estimates. So HCUP, for those of you who don't know, that's just a national project called the Healthcare Utilization Project. We use their estimates of bed day costs to provide care at the local hospitals. So I'm going to take a couple minutes and explain where these numbers actually came from, so you have a sense of how the economic evaluations were done and why the range is so large. We'll start with the first method. That's the one that came up with the $1.3 million. Now, remember I mentioned we don't have a comparison group for our study. So I can't just look at the counterfactual of what the cost to the healthcare system would have been had in clients been assigned elsewhere. Instead, method number one relies on what others have found in the literature. This is the idea of benefit transference I mentioned earlier. Well, it turns out there have been 4 rigorous cost studies that compare the cost of crisis residential alternatives to the cost of psychiatric inpatient hospital care. And the consistent finding across all 4 studies is that residential alternatives cost between 39 and 44% less than hospital inpatient settings do. Now, given that these studies were done years apart and in different parts of the world, that's a surprisingly tight band of estimates. So 39 to 44%. It was a consistent finding that residential settings are 39 to 44% less expensive than hospital counterparts. The studies also consistently found that there was no cost difference during the 6-month follow-up between those two settings. So whatever savings exist, those savings happen during the residential episode of care, not later on. All right, so how do we come up with a $1.3 million savings? It's pretty straightforward. I'll walk you through it. We began by using the results from the first analysis I shared with you a few minutes ago, in which we estimated that the average cost to the healthcare system per index in episode was just over $3,000 right there. Now, if we assume a 42.5% reduction in cost, then the comparable cost of providing that care in a psychiatric hospital setting would be just over $5,300. So the average savings per index in episode is a difference between those two figures, or $2,260. Now we know there were 1,719 in episodes during our 3-year study period, so the total savings to the healthcare system during our 3-year study period was just the number of in episodes during our study period times the average savings per episode, or about $3.9 million. But remember, that was over 3 years, so if we divide by 3, we see that using the in versus a psychiatric inpatient setting, using method 1 is estimated to save about $1.3 million annually to the healthcare system. Now, these savings are due to lower staff salaries at the inn versus local hospitals, but also to much lower overhead and operating costs. Think here in terms of psychiatric patients, they don't need operating rooms, they don't need ICUs. So the overhead associated with providing care for these patients in residential settings is much lower than the overhead of providing same care at hospitals. All right, let me share with you the second way we came up with these savings to the healthcare system. Excuse me. So in this one, sorry, I lost my place in my notes. Here we go. So in this method, instead of assuming that alternative residential settings would be 42.5% less expensive, like we did in method number 1, here we use national averages from HCUP of the cost of care in psychiatric inpatient settings, and we weighted it by primary diagnosis during at the time of admission to the inn. So the first 2 columns in the table, here and here, these show the specific psychiatric diagnoses that we used in the analysis and the number of each type of admission. So for example, out of the total 1,719 in episodes in the study, 878 patients had a primary diagnosis of schizophrenia or related disorder, and so on. The third column, right here, shows the average cost of a hospital stay, again, broken down by primary diagnosis at admission. And this is obtained by multiplying the bed day cost reported in the HCUP project times the average length of stay adjusted by primary psychiatric diagnosis. The fourth column, right there, the fourth column shows the actual average cost to the healthcare system per in episode as determined in our cost analysis that I shared with you a few minutes ago. Now, the next column shows just the difference by psych diagnosis of what it costs if integral care provides the care versus a hospital providing the care. And the final column, that simply multiplies the number of episodes for each diagnosis by the savings per episode, again, by diagnosis. So bottom line is down here in the bottom right number of this table. We see that over the 3-year study, this method estimates that the inn saved the healthcare system nearly $9 million, or about $2.9 million annually. Now, the truth is probably somewhere in between those two estimates, right? Somewhere between 1.3 million and 2.9 million. But either way, the inn is clearly a much more efficient way to provide healthcare compared to psychiatric inpatient settings. All right, now those first 2 analyses were from the healthcare system's perspective. The last analysis that I'm going to share with you today was done from integral care's perspective. Now, in this analysis, we answer the question, how much does integral care save by using the inn versus paying for inpatient psychiatric hospital stays? In other words, how much does integral care save by using an alternative residential setting versus paying a hospital to provide a similar kind of care? Well, the logic is pretty similar to what we've seen already. It's just that the perspective is different. Instead of taking the perspective of the healthcare system, we're just going to take the perspective of integral care here. So here's how we came up with our estimate. We know it costs integral care just over $2,900 per in episode. That was from our first analysis. We also know there are approximately 575 in episodes per year. So it costs Integral Care roughly $1.7 million each year to provide care at the inn. Now, instead, if Integral Care had to pay a local hospital roughly $5,000 per episode, and by the way, I didn't just make that number up, they actually do pay a local safety net hospital $5,000 per episode, it would have cost Integral Care $2.9 million to cover the same 575 episodes per year. So the potential annual savings to Integral Care is around $1.2 million. That is a difference between what it would cost Integral Care to pay that safety net hospital to provide the care and how much it costs Integral Care to provide that care themselves. Now, notice that I said, I hedged my bets here. I said potential annual savings. So the question is, are these savings real? Well, forget that next point. That all depends on Integral Care's constellation of payment, financing, and reimbursement mechanisms. And that analysis is beyond the scope of the study, but the potential is definitely there. Now, this last bullet point is just another way of getting to the 1.2 million. I'll just skip over that in the interest of time. All right. Now, before Tracy summarizes and we take your questions, I want to emphasize one important caveat to our study. That is, throughout all of our analyses, we assume that patient outcomes, both clinical and satisfaction, are similar between psychiatric inpatient settings and the inn. Now, I'm comfortable making that assumption because at least a couple dozen studies have consistently shown that clinical outcomes are the same between residential alternatives and psychiatric inpatient settings, while patient satisfaction is actually higher in residential settings. That said, we should still verify this assumption with Integral Care's client population. All right, that's it for me. Tracy's now going to summarize our talk, and then we will take your questions.
So as you all very well know, as members of the residential community, that there are several benefits of residential programs in addition to all of the outcomes that Todd just shared with us that supports our residential programs being of benefit. We also know that residential programs are a critical component of the care of continuum of care, in our healthcare system for psychiatric services. One of the benefits is that it keeps individuals connected to their community. That's quite different when someone's in an inpatient setting. There is an inherent disconnect that allows them to accomplish some of their goals that are needed to help alleviate the crisis that they're in. I see residential as both an intervention and a way to prevent future crisis. The work that's done with an individual while they're in residential programs is to help them build the skills that they need to be successful once they discharge. And residential services can be an in-lieu service when remaining in the community is too risky and when inpatient is not necessary, as I had mentioned earlier. And benefits individuals in need and cost-effective for the community. I think that was demonstrated quite well in Todd's presentation. For me, for my next step, practically, with this information and with these outcomes Todd has been able to demonstrate, this will help us further our conversations with our community and with insurance companies to hopefully build relationships and build a connection in order to offer services. Right now, I should say, we offer fee for services, and we would like to shift over to a bed day rate. And so this information can help support us advocating for our residential programs, particularly the inn, to get there. And I think we are ready for questions at this point.
Great, thank you.
Great. Thank you to Tracy and Todd for your information. I think that it was really eye-opening for some of us who work in programs and units like these, and just seeing the numbers. I mean, sometimes it can be overwhelming, but that data is extremely important to show the effectiveness of our programs. But it's time for questions, and we have a couple that came through. One is from Carrie. And Carrie wanted to know, have you looked at step downs from inpatient units for crisis residential and how much that potentially saves the system financially? Looks like I have Tracy on right now. Tracy, is that something you feel comfortable with answering? Todd might be working his way back.
I can sure try. We do have a continuum of care within our system, like was mentioned. So we do have a respite program that allows for step downs. In terms of evaluating that, we have not done that in the degree that we did for this this study on the inn.
Mm-hmm. Okay. And Todd was speaking about benefit transference when you originally started looking into studies like this. Did you find that was actually accurate? So essentially you had to compare, what you were looking to do with similar things. How did you find that was accurate once you were able to kind of work in the process of crisis residential? Was it similar or was it completely different?
Can you guys hear me at all?
Yes, Todd, we can hear you.
Oh, good. Okay. Tracy, is it okay if I answer that one? Okay. So it looks like my camera may not be loading, but at least my mic is working. Alex, to answer your question, we weren't able to actually compare directly what the cost of treating clients at the end would be to the counterfactual treating them somewhere else. The best cost required to treat clients at our local hospitals. It's a competitive environment. That stuff's not, it's all business confidential. We don't have access to that. So in lieu of that, we had to either, like I mentioned in the talk, use what others have found, that 42.5% cost reduction, or that was like a lower bound. The upper bound was just using national average bed day costs that were published by HRQ in their HCUP project. And so that there was a very big range, anywhere from $1.3 to $2.9 million. I was able to get, long answer to your question. I was able to get one state hospital, Austin State Hospital, which provided inpatient care for patients with psychiatric diagnosis. Their bed day cost was around $700 a day, as opposed to the $950 per day bed day cost provided by the HCUP project. So if we use their costs, and that's just only one hospital out of the several that provide care locally, then the estimate would be closer to $2 million instead of 2.9. So my best guess is it's between 1.3 and 2. But either way, that's a substantial savings in terms of system efficiency to the healthcare system, just from using the inn versus treating these patients in hospitals. Sorry for that long-winded response. I hope that made sense, though.
Yeah, no, that I completely understand. And another question from Carol is, to validate cost savings of the two, are you saying that you admit the same clinical presentation to inpatient as to your alternative settings? Are you saying that persons are inappropriately admitted or to inpatient units?
I can jump in on that, Todd, if that's okay. So our programs are designed as, an alternative to hospitalization. So we're not a hospital setting, so there is a degree of symptomology that would not be a right fit for a residential setting, being that it is a lower level of care. But we also know that oftentimes people end up in an inpatient setting unnecessarily. And I would, venture to say that part of that, at least in our community, is that's just been the process for so long. And so as we're building our residential continuum, there's ongoing education that we have for our community partners and law enforcement to help them understand that we are an alternative care site and to think of us prior to hospitalization.
Sure.
Just to add to what Tracy said.
Oh, go ahead.
Thanks. Just to add what Tracy said, It's not that patients are inappropriately admitted to inpatient hospitals. At least from the health economist standpoint, that's not it at all. It's simply that hospitals have such high overhead, and that contributes to bed day costs that are just much higher than they need to be. And so it's just sort of alternative residential settings have cost structures that are much lower than hospitals. And even if they got exactly the same kind of care, it's going to be a lot cheaper, even if clinicians have the same salaries. Just the
there you are.
Overhead and the infrastructure. She makes a good point. There's some patients that you wouldn't be allowed or wouldn't make sense to treat in an alternative residential setting.
I see. Do you have studies that look into dual diagnosed individuals with SUD?
In the literature that I reviewed in doing this project, a couple of papers disaggregated the costs by dual diagnosis, but only a couple did. And those patients with dual diagnosis tended to be much more expensive to treat. Unfortunately, I didn't have access to a dual diagnosis indicator within the client characteristic data I had to work with. So I don't know. I can't answer that, unfortunately. My guess is that they would be more expensive. But right now, all of the patients are parsed by either residential status, they're homeless or not, or marginally homeless, or by their psychiatric diagnosis at admission. And some of those folks, I'm sure, were duly diagnosed, but I didn't account for that.
Okay. Yeah, I understand. And Travis actually brought up a really great question and wants to know, have you guys brought this idea to commercial health plans, Medicare, or the VA? And if you have, can you share with us what that response was like?
To date, we have not.
Tracy, that's all you.
Yeah, that is the plan, I will say. At this point, it's not been utilized. It was a recently done study. And so our next step is to work with our business office and those who oversee our insurance contracts and use this as a tool. And that was really one of the ideas behind doing this study, to be able to have that hard data to demonstrate where the benefits lie in residential.
So another question is from Carol, who's in the Detroit, Michigan area. And she said they're looking for good criteria that distinguishes who succeeds in residential versus inpatient units. Do you guys have any recommendations for resources for something like that?
So our criteria was developed internally. Part of the criteria is informed by our regulatory standards. And the other part of that is defined, by what our actual resources are on site in the residential program. And so our criteria was developed with our associate medical director. And so ours is developed based on that, and also looking at what our community specifically needs.
And can I jump in real quick?
Yeah, absolutely.
Okay, cool. So this isn't directly answer the question, but it's sort of tangentially related. And that is, I know I'm preaching to the converted here, but dozens of studies that have examined this issue show that clinical outcomes for patients who go to alternative residential settings versus inpatient hospital settings there's no significant difference on any of them. But the other thing that I found really interesting was that client satisfaction is much, much higher in the alternative residential settings. And of course, we just, as we discussed, they're a lot cheaper. Now, the question still stands, though, is how do you determine the patients who should or best served in alternative residential versus inpatient? And like Tracy said, I think that's still a work in progress. And it's also probably evolving.
Can you tell me what the potential increases in reimbursement and cost savings if you were able to go from bed days to fee for service? bed days versus fee for service? Do you guys have an idea of what that would look like?
You're asking really good questions. However,
Well,
however,
technically that question is from Brenda McDonald. Thank you, Brenda.
Brenda, really good question. So the short answer is no, and here's why. So this study was really looking at the resource costs required to provide the care. So what did it cost the healthcare system, the local hospitals and integral care, to actually provide the care? It didn't even take a glance at what reimbursements might look at. Didn't look at charge, none of that. That gets really complicated, especially for integral care, because they're reimbursed in so many different ways. And so it's we just said, that piece of the analysis is going to have to come later, unfortunately, because integral care just has a whole constellation of financing and reimbursement policies. It's a great question, and that's where they're headed. And that from talking to their business office, that's clearly where they're going, but no idea, I don't think at this point, how much it would cost to go to bed day versus fee for service, and in terms of how they might be reimbursed.
So we're doing actually really well on time. And before I wrap us up, I wanted to know, and this is something that I thought of for our own programs locally here in Ohio. Have you seen where that return is? So the cost savings that comes from crisis residentials and programs of that kind, and us saving, potentially $1 million, if not more. Have you seen that redirected back into the mental health care system? Or do you know of any ways in which those funds have been redirected?
Another great question. I have not. I'm sorry.
That's
not
okay.
helpful in this regard. I mean, that's the goal, though, right? I mean, you want to connect the dots. If the alternative residential settings can reduce the overall cost to the healthcare system, somebody's saving money here. It'd be nice if alternative residential settings got some of that. I mean, the good news is somebody's improving, right? There's efficiency gains. Who's capturing it? Is it the insurance companies that have to pay less? Is it? It's not the hospitals. They're losing patients, but it's either the payers, or the residential settings to some extent. Now, if the payers are saving money, I don't know what they're doing with that, other than potentially lowering premiums, that sort of thing. That's a complicated question to find out. Whether there's several layers of stakeholders in that, and I'm not trying to cop out on the answer. I just honestly can't do it off the top of my head. Sorry.
No, and that could be potentially something we see later on down the line, in which we can actually see where that impact is, and what it is producing, when those dollars are reallocated or something of that nature. But Tracy and Todd, thank you guys so much. The information you gave was really enlightening, and it's something that we know very well with the CRA board, and that's information that we share passionately, because it really shows that our work is making a difference, not only in the lives of people, but financially as well. And it's just generally more effective. I want to wrap us up. I'm going to wrap us up for this session, and everybody who has joined us, I'm going to wrap us up for the day. We are done with day one of virtual Crisis Residential Association conference. This has been a new experience for all of us. And there's been other sessions where we might have had some technical difficulties. So I want to thank everybody for your patience with us today. And I am encouraging everyone this evening, do something self-care related, take care of yourself, do something that you enjoy, take a little bit of time to maybe do something that you learned from someone else today when we were in those chat and chew groups and we were networking and getting to know one another. Send each other some messages, say hello, and maybe explore the console a little bit more in that lobby, and get to know our platform a little bit more, so we can be ready when we get back together again tomorrow. Wonderful job, Tracy and Todd. Good job today. And everybody else, we will see you all tomorrow. We also have a board meeting. If we would love for people to join, our board meeting should be directly following this session. But if you cannot join, we are happy to see you all tomorrow. So everybody have a good day. Thank you. I think there we go.